Thank you, Dr. Hirschfield, and to all of you, members of the Brain and Behavior Research Foundation, as well as guests. It's my pleasure, really, to present our work on the fetal origins of mental illness and wellness. And I'd like for you to consider this kind of a prequel to a lot of the information that Dr. Friedman just presented on genetics and nutritional supplementation, as well as neurotransmitters and how they begin and are initiated during fetal life. So I've been primarily funded by an NICHD Women's Reproductive Health Research Award for the past 5 years, which has enabled me time and money to do some of this work. So connections between disturbances of early central nervous system development and neuropsychiatric diseases later in life have been acknowledged throughout the ages. In fact, while I would modify this statement slightly, made nearly 500 years ago, to the things desired by the mother, whether virtue or vice, are often found impressed on the child that the mother carries. This statement remains truthful today and frames our discussion on nature versus nurture in human growth and development. There are decades of scientific data as well that also relate the human prenatal psychobiologic experience to poor pregnancy and early childhood outcomes. In early infancy and childhood, outcomes such as preterm birth, which is birth too early or before 37 weeks gestation, low birth weight or birth weight less than 2.5 kilograms, as well as a prenatal or postnatal mood disorder during pregnancy, have been associated with behavioral and developmental delays in the children, as well as autism spectrum disorder. And later in childhood, adolescence, and early adulthood, these psychobiologic experiences have been related to schizophrenia, mood disorders in that individual, as well as chronic neurodegenerative and other degenerative diseases of adulthood. So I think that the National Child Welfare Association from 1919 deserves a lot of credit for already making these psychobiologic connections that advise women not to listen to old wives' tales, that no shock can mark an unborn baby and no horrible sight can deform him, but worry, fear, and anger may affect his mother's blood, which supplies his food, and therefore she should be calm, happy, and sweet-tempered, which is the ultimate goal of all the prenatal care that we provide. So this figure was published by a group out of Switzerland last year, but it depicts the interplay between an established genetic predisposition, genes that the mom and dad contribute to the fetus at the moment of conception, essentially, which is the blueprint that builds the brain before birth that Dr. Friedman alluded to. Then there's the prenatal period where the neurotransmitter operating systems mentioned begin to rapidly take form, and how nature begins to interact with nurture here. And then postnatally, how these are represented as various postnatal hits over the course of a lifetime. These are then influenced by repeated and cumulative exposure to various environmental risk factors, epigenetic changes, immune system activation, and aging. Repercussions of nature interacting with nurture can manifest throughout the life course in a broad spectrum of clinical and central nervous system diseases. From events that affect the brain structurally prior to birth, the neural tube defects that Dr. Friedman mentioned, as well as other CNS defects, through birth and the early postpartum period, early childhood manifesting as autism spectrum disorder, later in adulthood or early adulthood, schizophrenia, depression, and other mental illnesses, all the way to diseases that occur in advanced life, such as Alzheimer's disease, Parkinson's, and other forms of dementia. So what my point is that what happens here at this point in utero, where nature and nurture initially begin to communicate, really sets the trajectory for all of these events that may occur throughout the life course. So Dr. Friedman presented you with data and beliefs on how our lab believes this stage is set. The challenge is that it's difficult to measure what's going on here in real time during fetal life. And this is the challenge that Dr. Friedman and another one of our co-investigators, Dr. Ross, started posing to me when I was training in maternal fetal medicine a number of years ago. At the same time that they started posing this challenge, I was finishing up that subspecialty training in high-risk obstetrics. We also call it perinatology or maternal fetal medicine to make it really confusing. And at the time, I was really focused on the mother. Being a typical obstetrician, care of the baby ended pretty much the moment that I handed that baby off either to his or her mother or the pediatrician. But over time, I've maintained my respect for pregnancy and the mother, obviously, but have also gained a tremendous amount of respect and really awe for fetal development, and in particular, fetal brain development. So I'm studying and really care for two individuals at one time who in fetal life and even in early childhood are really inseparable. And so I want to emphasize that prenatal care and the interventions and support provided during pregnancy really has the capacity to have multi-generational benefits. Services that we might offer serve as a treatment and hopeful remission for a mother struggling with mental illness, but also have the capacity to prevent these illnesses in her child. So in prenatal care, we have to take a little credit. We're doing a lot of this. We already incorporate genetics, nutrition, including the folate supplementation mentioned by Dr. Friedman, and hopefully choline at some point in the near future. Environmental health and lifestyle factors like diet, exercise, stress reduction, the immune system, and psychiatry and social work collaboration, which is necessary for a lot of the moms I see in the county hospital in Denver. However, we're still a little bit disconnected because to an obstetrician, integrating mental health into standard prenatal practice still has some challenges. However, we are hopeful that as awareness around fetal programming of mental health becomes more widely understood and acknowledged, we have been poising ourselves in our research group to answer some of the questions that are unique to fetal programming of behavior, including mental illness and wellness. So taking the existing data into consideration and having specialized training in high-risk pregnancy and ultrasound, my goal is to discover non-invasive ways in which to assess a being with restricted access, the human fetus. To date, accessing the fetus has been challenging, as most direct fetal measures that we offer in pregnancy historically, such as amniocentesis or fetal blood sampling, are invasive and done really only in scenarios of increased risk or concern. These procedures also increase the risk of harm to the fetus and potentially pregnancy loss, and so are certainly not done experimentally. In my research, I use non-invasive, harmless measures to study human fetal brain development and fetal physiology in order to gain a more complete understanding of how these in utero factors influence trajectories of mental illness and mental wellness. So what have we learned so far over the past few years of work on these measures? In the study outlined above, we enroll women early in pregnancy, around 15 weeks gestation, which is just into the second trimester, and follow them at a number of pregnancy time points at the time of birth, and then up to about 3 months postpartum. Then they transition over into Dr. Friedman's and Ross's studies and are followed up to 4 years of age. So from the prenatal data, we know that we can non-invasively measure steroids, other hormones, and neuropeptides from a pregnant woman in her hair during the first, second, and third trimester, and from the fetus, whose hair we cut on the day of birth, to give us a retrospective record of hair and hormones that were deposited in that hair during fetal life. We've also learned from using our hair measures in tandem with assessments of maternal mood and stress hormone production that preterm birth, here, and I stole Dr. Friedman's picture to show you, this is a 32-week fetal brain. This is a brain at 40 weeks. So in a time period where we know the brain is making tremendous gains in size as well as synapses and development, that preterm birth may in part be caused by a negative interaction of too much psychosocial stress in the second trimester of pregnancy, which may lead to increased stress hormone production also in the second trimester of pregnancy, so only about midway into pregnancy in relation to preterm birth. We also have assessed relationships of these things in the first and third trimesters of pregnancy, but they're not nearly as strongly associated as these findings in the second trimester of pregnancy. So it's really the middle of pregnancy, maternal mental state, that appears to impact preterm birth. And we know that preterm birth is associated with adverse outcomes for that child that can be neurodevelopmental or physical, and be prolonged and extend over the life course. So we've collected the hair, we measured the stress hormones, and we've measured whether or not moms who were stressed and how this stress was related to when they deliver. From our data and other data in the world, the number one thing we want to do based on these data is to prolong pregnancy, to keep the fetus in utero as long as possible, because that's an obvious way to improve the lifelong health of this individual. We know that this, and then what we plan to do is go back using Dr. Friedman's data on 4-year-olds and compare it to the data that we've collected on fetal markers in utero to see what makes a positive or negative difference. We've also taken these data to the next level by seeking information on how the maternal psychobiology, in other words, the mom's mind and body connections, relate to her babies. So this figure represents our work on fetal stress hormone levels from the hair of babies who were born prematurely versus those who were born at term. While the babies born at term, here on the right, appear to have fetal stress hormone levels that correlate with their mothers in the in the third trimester, the premature babies have lower levels of stress hormones. You'll remember that the mothers in the second trimester had higher levels of stress hormones, and so they go in opposite directions. At this moment, this is an interesting but somewhat unexpected finding, but also highlights that we still have many questions to answer now that we're investigating fetuses in real time. So I always get this question, how does this investigation of fetal hair work? And how do you know you're going to have enough hair at birth to even study this? So this is a fetal ultrasound around 28 weeks gestation, so just into the third trimester. And I'm sure you're able to tell without the label, but what we have here is fetal hair. We can see it, fetal head hair. This is a skull, inside is a brain. This is some amniotic fluid around, and you can see hair swishing around in that amniotic fluid with fetal movement. So we feel fairly certain, and we measure this oftentimes in our study patients to try to get a proxy for what was the length that we measured in utero versus what's the length at birth, and get a fair estimate of how much hair growth has occurred during that time frame. But hair is actually present on the fetal head as early as 23 weeks gestation, and so can be 1 to 2 centimeters by the time of birth. So looking around the room, I'm sure that some of you have children and grandchildren who have tons of hair, more hair than I will ever have. However, some of you had children or grandchildren born with head hair, similar to this child. This is my little girl, Anna. She's had the least amount of hair of any child in our cohort, I can assure you. Even today, she's 3 and her hair quantity is pretty minimal. So with Anna, we had to be slightly less cosmetic with her haircut than we are with most babies, but even with her, we had enough hair to get good data out of it. So still, some of you have concerns that an obstetrician is also pretending to be a hairstylist. I'll acknowledge that. But luckily we have a team and a standard process for hair cutting now. It's evolved to be very cosmetic over time. So on the left is a mom. We cut mom's hair from the posterior vertex, so we're able to pin up the hair from the crown, take a very small strip of hair from this area. Then when we unpin the hair, it falls over, and moms can hardly tell the difference that we even took any. From the babies, it's a little harder to kind of take a strip of hair from about here, but most babies have a little fold of skin at the back of their neck, so we cut the hair along the nape of the neck while mom holds the baby upright against her chest. And by the time the hair is cut and the head is returned to a normal position, it's essentially invisible. We need about 20 to 30 strands of hair for adequate assessment. And so that's pretty easy to get from both mom and baby. And the other advantage to hair, aside from it being a retrospective marker for pregnancy and for fetal life, is that we can store it in aluminum foil at room temperature, which makes it very practical, cosmetic, and low maintenance. So lastly, during the second and third trimesters, we also add 3D imaging of the fetal brain to our standard obstetric ultrasounds that we do routinely for anatomy, assessment, and fetal growth. So I've shown a 3D image of one of our babies on the left. 3D ultrasound projects an image in 3 different dimensions that are routine images in which we measure the brain in adult life. And it enables us to analyze the developing brain structures. I also added a 2D image of kind of a halfway through sagittal plane of a fetal brain in the late third trimester, mainly to demonstrate how much we can already see as far as gyri and sulci and structures, and to let you know that we are able to store these data, and by storing it in 3D, we can go back, reconstruct it very similar to a CT scan or MRI, and look at similarities and differences as we follow these children out later in life. So in summary, so far we've developed and validated non-invasive long-term measures of the psychobiology of the mother and the fetus. This study will improve our understanding of the mechanisms by which nature and nurture interact in a fetus to establish trajectories of illness and wellness. And Dr. Friedman and Dr. Ross will go back to the stored data when they're seeing the 4-year-old child, including data on obstetric ultrasound, to determine factors that both positively and negatively influence that child during fetal life. By developing the capacity to do this, these data move us closer to an intervention to mitigate mental illnesses like schizophrenia in utero and promote wellness over the life course. I have many people to acknowledge, and primarily Dr. Friedman and Dr. Randy Ross, but a number of collaborators in our research team, as well as the Sidney Baer family and Brain and Behavior Research Foundation. So thank you.
Thank you. So we're going to try questions up here. So if you have a question, please come up to one of the microphones. Fascinating.
Thank you.
But now, are there other non-invasive techniques that you have to evaluate the fetuses and young children other than just hair?
So, as I mentioned, the hair, when we cut it on the day of birth, really represents kind of the third trimester of stress hormones, neuropeptides that we're trying to measure. We have started some work looking at fingernail growth of these babies.
Wow.
If any of you have had children or grandchildren, you know they have like little razor sharp nail tips when they're born. And we know that nail growth actually begins in the second trimester, probably as early as when we start to recruit these moms around 15 weeks. So we are looking into cutting the nails on the day of birth when we cut the hair, and seeing if that can be a fair proxy of things that happen in the second trimester, and then correlate that with the hair growth in the third.
Wow. Wow. So do you have any other recommendations for women about to give birth in terms of having healthy babies? And
one point that I think Dr. Friedman mentioned, but I just wanted to underscore a little bit more with regard to choline, is that with folic acid, as he mentioned, we know that it takes folic acid supplementation as well as a healthy diet to minimize the risks of open neural tube defects and cleft palate that he mentioned. But that is on a totally different scale of prevention than what choline could provide for amelioration of schizophrenia and other mental illnesses. So let's say that the baseline risk, and it's variable in different populations, but of an open neural tube defect is about 1 in 1,000. And we know that folate supplementation can reduce that risk to about 1 in 10,000. But schizophrenia occurs in about 1 in 100 individuals, or 1% of the population. So the population-wide effect of choline is potentially much larger. It's huge, really, compared to what we do for folate for a comparable nutritional supplement. And so I think that is really, of the things that we can advise during pregnancy, recommendation for choline supplementation, knowing that it's harmless, and potentially quite beneficial for that fetus and individual, is a simple thing that people can do. Hi.
Okay.
Hi.
Yes, ma'am.
I'm very interested in the choline conversation because I happen to have a daughter-in-law who's a pregnant obstetrician. And I actually texted her.
You're texting her right now.
I was texting her, and her prenatal vitamins do not have choline. She wasn't familiar with this, so she was on Amazon ordering it while you were talking. But I have a question.
We need an Amazon store.
We need something. But so the question I had was, is there too much choline you could take? And more specifically, she's pregnant with twins. Does that change the variable?
Those are tricky. That's tricky. So as far as is there too much choline to take, not that we know of in any detrimental way, other than a smell can start to develop in the mom when she takes a lot of choline.
Okay.
A lot of the nutritional supplements available now have tried to account for that. For twins, the best I can do is extrapolate. Although with folic acid supplementation in twins, we don't recommend additional folate. There are other circumstances, but more with medications that sometimes will recommend an increased dose. But one problem, and your daughter-in-law knows this well, is that in obstetrics, even if we have drug or supplementation data, we usually don't get the same quality of dose response data that we can get in non-pregnant populations, just because of the nature of doing trials in pregnant women.
Thank you.
Okay, one last question, then we'll have to move on. Yeah.
Besides knowing now why it takes so long for my wife to get a haircut, the question I really have here is that the numbers don't seem to add up. When you talk about nature and nurture, now this sort of fits into the nature category, whatever, but the numbers don't add up. In terms of genetically, you're likely to have, well, at least one out of, the percentage here is going to be more than 1 out of 4 could develop schizophrenia. Here it's 1 out of 2. What happens here between those two numbers? In other words, 1 out of 4 is looked at now as more 1 out of 4 is looked at as more environmentally mixed, and 1 out of 2 has to do with just women. You understand what I'm saying?
I don't understand. I'm sorry, I don't understand.
No, I'm sorry, I said it all wrong.
So I guess it really is just a question of nature and nurture, and how, whether this changes the balance in terms of risk factors, whether nature is a lot more. Is that fair enough? I think just if you want to do this quickly.
The numbers don't add up as far as what we say the associations are with the genetics versus what we say the associations are with other environmental influences.
I'm almost convinced it was either last year or the year before, the researchers seem to say, oh, now we've discovered that environment is about 50%, and genetically is the other part. Okay?
Okay.
Now you're talking, so that's the number one way, and now you're talking about something that's definitely 50%.
Okay.
So yeah. So and then we're going to have to move on. But
I think the process with genetics and the way that environmental factors, maternal mental health, and other influences in utero interact with even the genetic side, the nature side, is so complex that it's difficult to say that we can come up with any equation that adjusts risks really based on things that are quite unknown to us, especially as far as what happens in utero. But the other thing is that luckily, as a species, we are highly resilient. And so even if we are born with a genetic setup for a mental illness or other disease, in utero factors, as well as our early childhood experience and lifelong experience, whether that's in a scenario of adversity or a scenario of a lot of support and our mom took a lot of choline, can change our experience so much. And so because of that resiliency, it's really difficult to come up with a specific prescribed risk for any one individual.
Thank you. Thank you very much, Camille. Excellent.
Thank you.